2021 code set starting in January 2024. The 2021 E&M guidelines have undergone significant changes, particularly regarding the use of MDM and time. In this session, we will discuss these updates in detail. I believe this topic will be highly beneficial for all of us. Now, I would like to hand over it to Mr. Sheikh, who will introduce our speaker, Mr. Umesh Sharif, and also about the launch of our new YouTube channel. Thank you. Over to you, Sheikh.
Can you able to see the screen? Thank you, Sheikh and Sumi, for your introduction. Team, let me introduce myself. This is Omar from India. Today, I'm going to present you a topic on Evolution Management 2021 guidelines, which we are going to get implemented in Jan 1, 2024 in Abu Dhabi. Today's session is going to be quite interesting because we know what are the impacts we are going to have in the E&M domain. So I want it to be an interactive session so that it will be helpful for both of us. So I welcome you all for the session again. So in today's session, we are going to go through about the guidelines, roadmap, comparative analysis. We are going to see the key terms in the new MDM table. When I say about the key terms which is used in the new MDM table is going to play a vital role in finalizing the levels. So as like our previous MDM table, we do have table A, B, and C. We have mentioned as element 1, 2, and 3. And we're going to see the time factor. As SME said earlier, MDM and time is going to play a key role in determining the evolution management levels. So we also do have prolonged service codes, split share visits. We go through the frequent FAQs and we go through a few clinical scenarios. This content we are going to discuss in today's session. So let us have a quick recap. So healthcare professionals across a wide range of specialties report E&M safety codes on insurance claims to record the reimbursement for services performed in the office and outpatient settings. So the AMA, which holds a corporate of CPT and CMS, has implemented a major revisions related to I think someone has muted. Okay. Yeah. So hi team, welcome you all to AAPC Abu Dhabi local chapter. This is Umar Sharif from India. Today, I'm going to present you a topic on evolution management 2021 code set version, which we are going to implement in Jan 1, 2024 in Abu Dhabi. Today's session, I hope it will be interactive and quite interesting, and I hope this session will be useful for all of us. So without wasting much time, let me get into the topic. In today's session, we are going to review on the introduction, a roadmap of the E&M guidelines and E&M guidelines comparative analysis. And we are going to review on the key terms on the new MDM table. As you know, the new MDM table, we have quite many key terms, which is going to play a vital role in determining the levels. And also, as like our older MDM table, we do have element 1, 2, and 3, the same table A, B, and C with slight modification in the headers. And time and prolonged services and split share visits, FAQs, and clinical scenarios. So a short intro about a short recap about the E&M core services which we are reporting now. The healthcare professionals across the wide range of specialties report E&M services on the insurance claims to request the reimbursement for the services which is performed in the office and outpatient settings. So AMA and CMS have decided to implement a major revision related to office and outpatient settings, that is from code 99201 to 215 in the year of 2021. One goal of these changes was to streamline the coding and documentation requirements for commonly reported codes, and also to improve the quality of the care which is provided to the patient. Because in our earlier MDM table, we knew that the provider has to focus more on the documentation part. Even if the MDM medical decision making is quite complexity high, but however, if the patient has lacking history part, so the final level will be low. So that is why to improve the quality of the service which is provided by the physicians and to decrease the burden, the AMA has implemented a new set of guidelines and a new MDM table, which we will implement in the office and outpatient services as of now. So to understand the 2021 E&M coding changes, we should know the basics of the E&M codes. As Sami told, in earlier E&M services, we used to have a key components of history exam and MDM, and also we have a 50% of face-to-face counseling. These are the key factors to determine the E&M levels. From AIME 2021 code set, this is going to be based on the MDM or time. So to determine the correct E&M codes. So this is just just an example of both the 2020 code set and 2021 code set. As you see here, in the earlier code set we have a history, exam, and MDM, and the time factor is there. In the new code set we have only the MDM part and also the time. So either MDM or time is going to play a key role in determining the final level. So this is a roadmap of the E&M, what we have traveled from 1991 to 1992 to till date. So in 1992, there was no enough guidance. There was a financial impact on the provider's revenue. So in the year of 1995 and 1997, the CMS implemented a new documentation guideline for evaluation management services, and it was there for the past 20 years. In the year of 2000, there was a proposal to bring a new documentation guidelines because the guidelines which we already using, that is 1995 and 1997, it was quite older. So they thought, let us implement a new guideline. Unlike the earlier revisions in 1995 and 1997, in 2000 they called up all the domain experts, right from the physicians and coding experts. So they discussed and finally they proposed a new guideline. EMA proposed a new guideline in the year of 2021. So across the world, this guideline has already been implemented, and in Abu Dhabi and UAE, I think the code set is for going to implement in 2024 from Jan 1st. So this is just a comparative study of the key components. You can see there was in 1995 it was based on the system based, and in 1997 it was a point based, and you can see in 2021 it is based only on the MDM and time. It doesn't mean that we don't require history in exam. History in exam will be still there in the medical record, but it will be medically appropriate. Okay, but it will not play a major role in determining the level. So history and exam can be documented on behalf of the physician. It can be documented by any support staffs. From MDM time, it will be documented by the physician. So the same 1995-97 history, exam, MDM or time. And from 2021 code set, it's going to be a MDM or time. So the same thing which we discussed now. So just an icebreaker. An established patient who has follow-up visit for asthma and hypertension management, and the product documents a medically appropriate expanded problem focus history and exam. The physician performs an independent interpretation of the pulmonary function test, and the provider makes a change to current prescription for asthma and hypertension. So as per the earlier guidelines, which we are currently following, this would be the overall E&M level will be 99213 with the two stable chronic illness for table A, 2 points, and table B, it is for independent interpretation of the pulmonary function test, that is going to be 2 points. And the risk table, that is for prescription management for two chronic conditions, that will be moderate. So I want to make a note here. The session which I'm currently conducting, it's purely based on the AIME 2021 code set. I knew that there is a slight variation in the guidelines which we follow in UAE. So this session is only based on the AIME code set. If we do have any guideline change or any revision based on the Tasneem guidelines, we are going to follow them. So in 2021, as per the 2021 guidelines, table A will be moderate, that is 2 or more stable chronic illness, moderate. And table B, it will be moderate because independently interpreted test that falls under the moderate level. And the risk for prescription drug management is moderate. So the overall MDM level, overall E&M level will be 99214. So we can see the clear difference between the earlier guidelines and the current new revised guidelines. this is what we discussed. It's going to get implemented and for office and other outpatient services will be implemented. The new revision will be implemented in Jan 1, 2024. We do have other E&M service categories, but there will not be any change. Further changes will be announced later. So as of now, the guidelines is going to get implemented only for the office and outpatient services. So it means we will have two MDM tables. The new MDM table which we are going to apply for the office and outpatient services, and the other MDM table which we are currently following will be for the other E&M services. Any doubts? Any clarification till now, team? If you have any doubts, we can discuss at the end of the session. Okay. So one of the key changes in office outpatient services is they have removed the CPT code that is 99201. So moving forward, there will not be a code 99201 for new office visit patients. So we are going to have the code range from 99202 to 205 for new office visit patients. And for established patient, we have 99211 to 99217. So we'll go through. So just a quick recap. So chief complaint, yes, we do need a chief complaint for all the medical records, and HPE and exam that just a medically appropriate notes will be documented. That's it. So regarding the new MDM, there is a slight change in the header. So earlier it was a number of diagnosis and management option, number of diagnosis or management option, and now as per the new MDM table, the header has changed as number and complexity of problem addressed, COPA, and the table B, that is amount and or complexity of the data to be reviewed, has changed into amount and complexity of data to be reviewed and analyzed. So the third table C is the risk of complication and or morbidity or mortality has changed as risk of complication and or morbidity or mortality of patient management. So the key terms. So please give attention, because the key terms is going to play a vital role. So the key terms used in the team, can you able to hear me? I'm audible now. So the key terms which is used in the new MDM table. So as I said earlier, the key terms is going to play a major role. So please focus on the upcoming slides. So if possible, if you need any notes to be taken, I will give some time so that you can take notes during the slide during the session. Okay. So in the key terms, I added a few examples, okay, which is not there in the EMA CPT 2021. For the purpose of audience, for the purpose of the listeners, I just added the examples. So whatever there is as an example, it is given by myself. So a problem is a disease, condition, or illness, or injury, symptoms, signs, and findings of complaint, or anything which is addressed at the encounter. Problem is something, the reason for which the patient visits the hospital. Okay, it can be a disease, it can be a condition, or it can be an illness, or it can be injury, or it can be signs and symptoms. It could be anything for which the patient visits the hospital. So problem addressed. When I say problem addressed, a problem is addressed or managed when it is evaluated or treated at the encounter by the physician or other qualified healthcare professionals reporting the services. This includes consideration of further testing or treatment that may not be elected by virtue of the risk-benefit analysis or patient, parent, guardian, surrogate, or choice. So when you say problem addressed, uh, the condition for which the patient is visiting the hospital and the condition which the physician has addressed during the encounter. Okay. So there might be the cases where the patient came with a complaint of headache, and the physician might have done the neurological examination, neurological management, and final impression is documented as headache. While performing a physical examination, the physician noted the patient has some rash. However, the patient has not performed any medical management for the rash, but in the impression, he is documenting just a referral to dermatologist. So, in case if the physician is going to just going to document a referral without evaluation, that would not be considered. That would not be considered for problem addressed. So, please give little attention on the problem, whatever is addressed during the encounter. So whatever the address, it can be anything. If the physician is going to address a condition, only that would be considered for problem addressed. For the inpatient and observation services, the problem address is the problem stated on the day of the encounter. As we know very well, a patient may get admitted with a complaint on the day one. The patient may be admitted with certain complaint, and on the subsequent day, the condition may get progressed, a condition may get improved, and also during the stay of the hospital, the patient may get further infections or any condition. So the problem addressed for inpatient and observation services will be the problem which was addressed on the day of the encounter. That is based on the particular dose. Okay, not based on the condition for which the patient is admitted. So the next one is a minimal problem, a problem that may not require the presence of physician or other qualified healthcare professionals, but the service is provided under the physician or other qualified healthcare professional supervision. So for 99211, we don't have any MDM. So 99211 is reported by the nursing staffs as per the EMA CPT guidelines. So it could be like suture removal or dressing change for which the immediate which can be performed without the physician supervision. So that is the minimal problem. Self-limited or minor problems are those problems that runs a definitive course and a prescribed course is transient in nature, and it's not likely to permanently alter the health status. Like very simple examples like cold, insect bite, tinea corporis, etc. So there are self-limited or minor problems. They are transient in nature. A sprain. If we do have a sprain after getting after quite some days, if we rest, we will have a full recovery without any function impairment. So such condition will be considered for acute uncomplicated illness or injury. It's a short-term problem. So I've given an example here. The patient came with a complaint of ankle pain. The exam is limited to the ankle. X-ray was not performed and diagnosed with simple ankle pain, ankle sprain. And there's another patient with a nasal congestion, no testing done, diagnosed as URI. These are acute uncomplicated illness or injury. So there are certain cases where the condition will be acute uncomplicated illness. However, the treatment will be provided in hospital setting. So you may ask me whether why if the condition itself is an acute uncomplicated, why we require the treatment to be provided in hospital inpatient settings. The reason is there are some cases where the patient might be elderly patient or the patient patient might be an infant or another patient. So in such cases, the treatment would be performed in the hospital inpatient or observation level of care. Acute uncomplicated illness, however, the treatment is delivered in the hospital inpatient or observation level of setting. Full recovery without functional impairment is expected. So let's move on to the acute illness with systemic symptoms. An illness that causes a systemic symptoms and has a high risk of morbidity without treatment. For systemic general symptoms like such as fever, body ache, fatigue in a minor illness that may be treated to elevate the symptoms. See the definition for self-limited or minor problem or acute uncomplicated illness or injury. So patient is having acute illness, along with that the patient is having a systemic symptoms. So example, the systemic symptoms may not be general, or it may be the single system. Say for example, pyelonephritis, pneumonitis, and colitis. If the patient is having colitis, obviously the patient will have fever, nausea, vomiting, abdominal pain. All these are systemic symptoms. So let us move on to the acute complicated injury. An injury which requires a treatment that includes the evolution of the body system that are not directly part of the injured organ, and the injury is extensive, or treatment options are multiple and are associated with risk of morbidity. So as the word indicates, the patient is an acute condition, but acute complicated injury. The best example would be head injury, where the patient performs a neurological examination, but he doesn't stop there. He also evaluates the other body systems to make sure that everything is fine. So we can also have a indication like a mechanism of injury can also be an indication for acute complicated injury, like fall, motor vehicle accident, fight, or any other accident that requires a physician or qualified healthcare professional to evaluate the multiple organ systems or body areas to identify or rule out any injuries. Example, head injury with brief loss of consciousness, and the patient is having hand laceration, neurovascular exam is done, diagnosed with laceration of hand involving tendon. So let us move on to the next key term. So stable acute illness. Okay. Now a problem that is new or recent for which the treatment has been initiated. Earlier case we saw a patient with sprain, right? The same patient came once again to hospital. Okay. For the patient, we already started the treatment. Now the condition is improved. The patient is improved. The while resolution may not be complete, it's stable with respect to the condition. Example, the sprain for which the treatment was already initiated, now the condition is improved. That is the stable acute illness. So the next key term is undiagnosed new problem with uncertain prognosis. A problem in the differential diagnosis that represents the condition likely to result in a high risk of morbidity without treatment. Example, a lump in breast. So any condition that is quite undiagnosed, a new problem, and physician is not sure what would be the prognosis of the condition. Example, the patient is having a lump. The patient is not able to confirm whether the condition would be progress as cancer or it will be a normal lump. Okay, so that will be your undiagnosed new problem with uncertain prognosis. It could be cancerous or it can be a non-cancerous lump or lesion. So stable chronic illness. Okay. So next key term is till now what we discussed is related to the acute illness. Let us move on to the chronic illness. So stable chronic illness. Before we discuss on the stable chronic illness, let us discuss what is chronic illness. So because we have difference of opinion because we have multiple condition patient encounters with multiple past medical history. So based on the current medication which is patient taken at home, we consider as chronic illness. But however, now as per the new guidelines, the AMA has given the new guidelines that the chronic illness is a problem which is expected duration of at least 1 year or until the death of the patient. For the purpose of the defining chronicity, the conditions are treated as chronic, whether or not stage or severity changes. Example, uncontrolled diabetes or controlled diabetes or single chronic infection. So chronic illness is nothing but a condition which is expected duration of at least 1 year, or it lasts till the death of the patient. Okay. Now let us move on to the word stable. So for the purpose of the stable, for the purpose of categorizing MDM, is defined by the specific treatment goal for the individual patient. So a patient who is not at his or her treatment goal is not stable. Even if the condition has not changed, there is no short-term threat to life or function. For example, a patient with persistently poorly controlled blood pressure, for whom a better control is a goal, is not stable. Even if the pressures are not changing, the patient is asymptomatic. The risk of morbidity without treatment is significant. Okay, let me explain further on this. Okay, so say for example, let us consider an example of hypertension and hypertensive and diabetic patient. So as we know, for the hypertension and diabetes patient, always the blood sugar level and the blood pressure level will be always quite little elevated comparing to the normal individuals. So the physician defines that physician prescribes a medication. The objective of prescribing the medication is not to reverse the hypertension or not to reverse the diabetes mellitus. Rather, the purpose of prescribing the medication is to have some treatment goal. Say, for example, the physician will decide that, okay, let me control this patient blood pressure around somewhere around 130 to 140 or 130 to 150. So if the treatment goal is achieved, then that would be considered as a stable chronic illness. So let us move on to the next key term, that is chronic illness with exacerbation, progression, or side effect of the treatment. The chronic illness that is acutely worsening, poorly controlled, or progressing with an intent to control progression and requiring additional supportive care or requiring attention to treatment for side effect. So a patient has a chronic illness which has started acutely worsening. So it has started exacerbate. Okay. So the example given here is patient with a shortness of breath. Yes, the patient has a history of asthma. Now the patient is having shortness of breath. Okay. The patient visits hospital. No respiratory distress was found at the exam. Pulse oximeter is 98%. The nebulizer treatment was provided and diagnosed as asthma exacerbation. So that will fall under the chronic illness with exacerbation, progression, or side effect. So the next key term is chronic illness with the severe exacerbation. Earlier it was chronic illness with exacerbation, and now it is chronic illness with severe exacerbation. So the severe exacerbation or progression of the chronic illness or severe side effect of the treatment that have significant risk of morbidity and may require the escalation level of care. So now the chronic illness has severely exacerbated, so the immediate attention should be provided. The escalation level of care is required. Example, the patient with palpitation and lightheadedness and past history of hypertension. Now the patient blood pressure is around 197 to shooted up to 197 to 110 and diagnosed with hypertensive urgency. Okay. That is your chronic illness with severe exacerbation. So finally, the last key term in table A, that is for problem COPA, is acute or chronic illness or injury that poses a threat to life or bodily function. An acute illness with systemic symptoms, an acute complicated injury, or a chronic illness or injury with exacerbation or progression of a side effect treatment that poses a threat to life or bodily function in near term without treatment. So any acute or chronic condition, if in case that poses a threat to the life or bodily function, that will fall under this particular key term. So some symptoms may represent a condition that is significantly probable and poses a potential threat to life or bodily function. These may included in this category when the evolution treatment are consistent with the degree of potential severity. Here I have given a few examples. Okay. Again, I repeat, what are the examples which I used in this presentation? Okay, that is solely for purpose of defining the key terms. It is not documented in the AMA CPT 2021 guidelines. For example, the multiple trauma, acute MI, intracranial injury, skull fracture, femur fracture, pulmonary embolism, severe respiratory distress, progressive severe rheumatoid arthritis, psychotomies with potential threat to self or others, peritonitis, and acute renal failure, etc. So the next key term which we are going to discuss is pertaining to the data table, that is table B, the analyzed. So the process of using the data as a part of MDM, the data element itself may not be subject to analysis, but instead included in the thought process for diagnosis, evaluation, or treatment. The tests ordered are presumed to be analyzed and the results are reported. So whenever a test is ordered, it is presumed that the results is reviewed and analyzed. Okay, that if a physician orders a particular test, it is it is presumed that the same physician has to review the results and document. Therefore, when they order and therefore when they are ordered during an encounter, they are counted in that particular encounter. The tests that are ordered outside of the encounter may not be counted in the encounter in which they are analyzed. In case of recurring order, each new results may be counted in the encounter which it is analyzed. For example, an encounter that includes an order for monthly prothrombin times would count for one prothrombin time ordered and reviewed. The additional future results, if analyzed in a subsequent encounter, may be counted as single test in the subsequent encounter. Any service for which the professional component is separately reported by the physician or other qualified healthcare professional reporting the ENF services is not counted as a data element, ordered, reviewed, or analyzed, or independently interpreted for the purpose of determining the level of MDM. To make it short, any service, again, the last 4 lines, any service for which the professional component, if in case the physician is going to report a professional component separately along with the ENM services, in such cases, we are not going to consider that for order for calculating the order point, review point, or interpretation point. That is what documented here. Okay, let's move on to the test. The next key term is test. Test or imaging, laboratory or psychometric or psychological data. A clinical laboratory panel, example, basic metabolic panel, is a single test. The differentiation between a single or multiple tests is defined in accordance with the CPT code set. For the purpose of data reviewed and analyzed, pulse oximetry is not a test. Okay. So, as per the new MDM table, each unique test is defined based on the CPT code set. Say for example, here they have given an example of basic metabolic panel. So we knew very well that the basic metabolic panel itself consists of multiple tests. So say for example, you can see here, the basic metabolic panel consists of calcium ionized, calcium carbon dioxide, calcium ionized, carbon dioxide, chloride, creatinine, glucose, potassium, sodium, and urea nitrogen. So if the physician has performed all these tests, even though they are multiple tests, since we do have a CPT code set for this particular panel, we will consider that as a single test. So you may ask me, so what if in case if the physician is going to perform any of quite 1 or 2 to 3 tests among this group? So in such cases, that will be considered as an individual test, not as a single test. I repeat. So in basic metabolic panel, we have 1, 2, 3, 4, 5, 6, 7, 8 tests. So all this 8 tests together considers one falls under the basic metabolic panel that will consider as a single test. If in case patient is going to perform only the calcium ionized and carbon dioxide, that will be considered as 2 individual tests because we don't have a panel. We don't have a panel test representing these 2 tests alone. So each unit test is defined by the code set. That's what we discussed now, not the number of the tests performed. If the provider orders a panel test that contains tests with an individual CPT codes, all those individual CPT codes are bundled into the CPT code for the panel test and counted as one unit test. Example: provider orders electrolyte panel that is 80051. Although this panel includes 4 tests, that is carbon dioxide, chloride, potassium, and sodium, this is considered and counted as one unique test and not 4, and reported with 80051. So that is what we had an earlier example. Here I had given one more example for better clarity. Okay. When multiple results of the same unit test with comparison of one unit test, even though multiple results are reviewed. When multiple results of same unit test with comparison count as one unit test, even though the multiple results are reviewed. For example, the provider orders a serial glucose testing over several hours or days and compares the result during the ENM services. Although the same test is repeated multiple times, the technical correction states that the serial test counted as one unique test. Further, regarding the unique test, there are certain tests which have overlapping elements that are not unique. Even if they are identified by 2 distinct safety codes, example, a complete blood count with the differential and a CBC without differential will constitute as one test. Here I have given the example here. CPT code 85025, the blood count complete automated consists of hemoglobin, HCT, RBC, WBC, and platelet count, and automated differential WBC count, and CPT code 85027, that is blood count complete and automated HGB, and HCT and RBC, WBC, and platelet count are considered as one unit test. That is because they have overlapping components. So these two tests, though they have a 2 CPT codes, but still, since they do have the overlapping component, that would be considered as a one unique test. Okay. So further key terms, we have a combination of data elements, a combination of different data elements. For example, a combination of notes reviewed, test ordered, test reviewed, and independent historian allows these elements to be summed. It does not require each item type or category to be represented. A unit test is ordered plus a note reviewed and the independent historian would be a combination of 3 elements. Okay. So when you say combination of data elements, it means when a test is ordered plus a note reviewed and the independent historian would be considered as 3 elements. Even if there is a multiple test, that will consider for a combination of data elements. So the next key term is external. External, as the word indicates, it's external records or communication or test results are form of external physician or other qualified healthcare professional care organization. Further, external physician indicates external physician or other qualified healthcare professional. An external physician or other qualified healthcare professional who is not in the same group practice or is of a different specialty or subspecialty. This includes a licensed professional who is practicing independently. The individual may also be a facility or organization provider, such as from the hospital, nursing facility, or home healthcare agency. So in certain cases, we do see that the patient would discuss the case with the external physician who may not from the same group practice, okay, for the management of the patient condition. So, for example, like a PCP discusses with a cardiologist when the patient is having a cardiac complaint, he discusses over the call with the external physician for how on management of the patient health condition. As external physician is someone who is not from the same group practice. So discussion requires an interactive exchange. The exchange must be direct, not through intermediaries. So the discussion, as I said earlier, when the PCP discusses with the cardiologist, he has to discuss. The interaction should be direct. It should not be through the intermediaries like clinical staff or things. Sending a chart notes or written exchanges that within the progress note does not qualify as interactive exchange. The discussion does not need to be on the date of encounter, but it is counted only once and only when it is used in the decision making of the encounter. It may be asynchronous, it does not need to be in person, but it must be initiated and completed within a short period of time. So next is independent historian. An individual, example, a parent, guardian, surrogate, spouse, or witness who provides an history. In addition to the history provided by the patient who is unable to provide a complete or reliable history, it might be due to a development stage, dementia, or psychosis, or because to or because a confirmatory history is just to be necessary. There may be cases where the physician obtains an additional history where the patient might be mentally retarded, or the patient might have a dementia, or the patient due to the patient's age factor, the patient will obtain an additional history from either from the parent or guardian or surrogate or spouse, or in case of accident cases, the patient might get an additional history from the witness. So this will be considered as an independent historian. In case where there may be a conflict or poor communication between multiple historians, more than one historian is needed. The independent historian requirement is met. It does not include translation services. The independent history does not need to obtain in person, but does need to obtain directly from the historian providing the independent information. So the translation services is not to be considered as an independent historian. Okay. So next, let us move on to the independent interpretation. So before we discuss on the independent interpretation, once again, I just want to give a insight on the term order, review, interpretation. So these three terms are quite interrelated to each other. So order is something the physician orders a test, and review is a part of order. It means whenever we are going to give credits to order, we should not give credits to review, because the review is a part of the order itself. Okay. Now we left with two terms, that is the review and interpretation. So review is something the physician just reviews the test and he documents. When it says interpretation is something, say for example, a patient came with a complaint of knee pain, and the radiologist performed the X-ray, and the radiologist documented his finding. Now, from the physician point of view, he can review the result which the radiologist has provided, or he can interpret from the image which is taken by the radiologist, and he can give an interpretation from his side. So that would be documented as independent interpretation. The independent interpretation of the test for which there is a CPT code and an interpretation or report is customary. This does not apply when a patient or other qualified healthcare professional who reports the E&M services is reporting or has previously reported the test. A form of interpretation should be documented, but need not conform to the usual standards of complete report for the test. So anything, the patient has to document what he has interpreted from the image. That should be documented in the medical report.
Yes.
Then there is some background noise. Let us move on to the next key term, that is appropriate source. For the purpose of discussion of the management data for table 1, an appropriate source includes the professionals who are not healthcare professionals but may be involved in the management of the patient. Example, lawyer, parole officer, case manager, teacher. It does not include the discussion with the family or informal caregivers. Okay. So finally, let us move on to the table C, that is the risk table. So when we discuss about the risk, risk is something which the physician determines based on the condition of the patient. Okay. So the probability or the consequence of the event. Risk is the probability and or consequence of the event. What was the outcome of the condition? That will be considered as a risk. Patient is having head injury. It could be a normal head injury. Patient is having head injury with a loss of consciousness. Patient is having head injury with intracranial bleed. The patient is having a head injury with skull fracture. So the condition is same. The patient had a head injury, but what was the outcome of the condition? That will be considered for risk. The assessment of the level of risk is affected by the nature of the event under consideration. For example, a low probability of death may be high risk, whereas high chance of minor self-limited adverse effect of the treatment may be a low risk. Definition of the risk are based upon the usual behavior and thought process of the physician and other qualified healthcare professionals in the same specialty. So risk is solely depends on the physician management. So trained clinicians apply a common language usage meaning to terms such as high, medium, low, or minimal risk, and do not require quantification for these definitions. So the risk cannot be quantified. Though quantification may be provided when there is a evidence-based medicine has established probabilities. For the purpose of the MDM, the level of risk is based on the consequence of the problem addressed at the encounter when appropriately treated. That's what I said. The risk is based on the outcome of the condition. That is what mentioned. What was the consequence of the condition? That is considered for the risk. This also includes MDM related to need to initiate or forgo the further testing, treatment, or hospitalization. The risk of patient management criteria applies to the patient management decisions made by a reporting physician or other qualified healthcare professional as a part of reporting encounter. So the next key term is morbidity. The morbidity is a state of illness or functional impairment that is expected to be a substantial duration in which function is limited, quality of life is impaired, or there is an organ damage that may not be transient despite treatment. So social determinants of health, the economic and social conditions that influence the health of the people and communities. Example may include food or housing insecurity. The patient might be homeless, the patient might be jobless. That directly impacts on the patient's health status. Okay. So I just wanted to add a note here. The social determinants of health status includes smoking and alcohol use. According to the Center of Disease Control (CDC), the social determinants of health encompass the economic and social conditions that influence the health of the people and communities. It typically includes homelessness, food insecurity, unsafe living condition, access to clean water, pollution-free air, and economic insecurity. One specific example is not having the money to afford medication. It does not include smoking and alcohol use. So the next key term is surgery, minor or major, elective or emergency procedures or patient risk. So surgery, minor or major, the classification of surgery into minor or major is based on the common meaning of such term when used by the trained clinician, similar to the use of term risk. As I said earlier, just like risk is defined only by the physician, the surgery will be considered whether it's a minor procedure or major procedure. It solely depends upon the physician terminology. So these terms are not defined by the surgical package classification. So we do have in CPT, we do have a surgical global package of 10 days and 90 days global package. So where we consider that as a minor surgery or major surgery, but that is nothing related with the E&M services. So as per here in the in the MDM table, surgery major or minor is going to be based on the physician determination. Okay. So we do have elective surgeries and we do have emergency surgeries. Elective surgeries are surgeries that is planned earlier, and emergency surgeries are those surgeries which is performed immediately with minimal delay to allow the patient for stabilization. The best example of emergency surgery is appendicitis, and elective surgery, the patient might most micrographic surgery or certain surgery which is performed stage by stage. So it is a pre-planned surgery, that is your elective surgery, and emergency surgery is something which is performed immediately. So surgery risk factors and patient procedure. Risk factors are those that are relevant to the patient and procedure. The evidence-based risk calculators may be used, but not required in assessing the patient procedure risk. So finally, the last key term we do have the drug therapy, requiring intensive monitoring for toxicity. When you say drug therapy, okay, here we are not discussing about the drug therapy, the therapeutic drug therapy which we commonly use. Here, these drug therapy or those drugs which we should have a intensive monitoring of toxicity. The best example is chemotherapy drug. A drug that requires intensive monitoring is a therapeutic agent that has a potential to cause a serious morbidity or death. So, if in case what happens if we are not, what happens if a cancer chemotherapy drug is not monitored? It may lead to a consequence and patient may die. So, the frequent monitoring should be performed to see the efficacy of the drug and to monitor. So the monitoring is performed for assessment of these adverse effects and not primarily for assessment of therapeutic efficacy. The monitoring should be that which is generally accepted practice for the agent, but may be a patient specific in some cases. The intensive monitoring may be long term or short term. The long term intensive monitoring is not performed less than quarterly. So the monitoring may be performed with the laboratory test or psychological test or imaging. The monitoring by history or examination does not qualify here. The monitoring effects of the level of MDM in an encounter, which is considered as a management of the patient. As I said earlier, the example is example of maybe the monitoring of cytopenia in the use of an anti-neoplastic agent between dose cycles. And also we do have some diabetes patient we fit in an insulin who will be under the insulin therapy, and every month the patient undergoes a glucose monitoring test, but that will not be considered for intensive monitoring for toxicity. The example of monitoring that do not qualify include a monitoring glucose from which slide I was on. Team, if you drug therapy slide. Okay. Okay. So drug therapy, those drugs which requires intensive monitoring for toxicity. The best example will be a chemotherapy drug. When the patient prescribes a when the patient undergoes a chemotherapy, the patient monitors the therapeutic efficacy of the drug and also checks the condition of the patient. So the next example is related to the glucose level monitoring during insulin therapy, which does not consider for intensive monitoring of toxicity. Here, the purpose of performing the glucose level test, a monthly test, is just to know the glucose level, not the toxicity of the glucose. So finally, till now, whatever we discussed, that are the key terms which is used in the MDM table. So this is the MDM header. As I said earlier, the MDM header has slightly changed. It is not the same. So it is going to be the same 2 bar 3. So element 1, that is number and complexity of problem matters. This is the old table which we are already using, and this is a new table which we are going to use. Okay. So here you can see for 99211 we don't require any MDM part. For 99202 and 99212, the minimal one self-limited or minor problem, that is straightforward MDM. For low, that is 99203 to 99213, 2 or more self-limited problems, one stable chronic illness or one acute uncomplicated illness, that will be considered for low. For moderate, that is for 99204 to 99214, one or more chronic illness with exacerbation, 2 or more stable chronic illness, one undiagnosed new problem, one acute illness with systemic symptoms, or one acute complicated injury. If any of this criteria are met, that will be considered as a moderate. For high, that is 99205 or 99215, one or more chronic illness with severe exacerbation, one or more chronic illness, one acute or chronic illness that poses a threat to life or bodily function. So this is scope of the first table, number of problem addressed, number and complexity of problem addressed. So the next table is related to the amount and or complexity of data to be reviewed and analyzed. So this is the earlier old table which we are following, which we were following, and this is the new table. Okay. So here you can see they have categorized into category 1, 2, category 1, 2, 3, and category 1, 2, 3. So what is this? How we are going to apply that we'll see in the further slides. As of now, I just want you to make a note here. The category which is mentioned in limited is not the same with moderate. Okay, so both are different. So here you can see in the category 1, it is mentioned as review of external note, review of the results, a review result of the test, and ordering of the unique test. But here in the moderate and high, you can see category 1 is review of the external note, review of the results, a review of the ordering of the unique test, and assessment referred in the independent historian. So for each category, it varies. So the low MDM, here it satisfy any one of these two categories. So you can see here. So for limited or low, any one of these categories should met. So category 1, test and documents for the any combination of two of the following. To meet the category 1 itself, we should require any two of this any two of the following, either the review of the external notes or review of the result of each unique test or ordering of the each unique test. Again, I repeat, review is a part of order. So you might ask me why it is mentioned as review here. So in certain cases, the patient might already might have seen by the primary care physician. The primary care physician had performed order as a test. The test was ordered by the PCP, and in case the patient visits the hospital, if in case the patient is going to review the results of the test which was ordered by the physician, we can consider for a review point, because the criteria for considering review order and review is the same physician should have ordered and same physician should have it reviewed. In such cases, we will give credits only for the order. In case there is a case where the order was given by some other physician and only the review is performed by our physician, then we can give credits for the review. So category 2 is assessment required in the independent historian. So for limited low or MDM, we require at least one of these two categories to be met. So for moderate MDM, so we have category 1, 2, 3. At least one of these three categories should have met. So for category 1 in moderate MDM, we have review of external notes, a review of the result of unit test, ordering of the unit test, and assessment requiring independent historian. So any three of these points should met for category 1. So category 2 is independent interpretation of the test performed by the another qualified or the other healthcare professional, not separately reported. If in case it is separately reported, then they could not be considered for category 2. So category 3, discussion of the management of the test interpretation with the external physician. So for moderate MDM, at least one of these three categories should have been met, either category 1, either category 2, or category 3. For high MDM, the same category 1, 2, 3 remains the same, like your moderate, but here it should be at least 2 out of 3 categories. So I can show you the previous slide here. You can see here for moderate and extensive. For moderate and extensive, the high MDM, category 1, 2, 3 are same. The points which is there in category 1, 2, and 3 are same for both moderate and extensive. Here it is 1 out of 3 category, but here it is 2 out of 3 categories. For limited, it's totally different because we have different categories. For limited, it is 1 out of 2 categories. The category 1 is different and category 2 is different. So always when we check about the data points, we should see the particular level, and then we have to see the categories. So risk, this is the risk table which we followed earlier. So management options, and you can see there is, this is the previous MDM table, and the new risk table, it is it. So as I said earlier, for 99211 we don't have any risk. For 99202 to 99212 there's a minimal risk, and 99203 to 99213 a low risk. We don't have any criteria here. That is solely based upon the patient's condition, which is documented by the physician. Because as I said in the earlier slide, risk cannot be quantified. We cannot say this condition is going to follow for this condition is going to fall into this particular risk. No, we cannot say. Risk is solely based upon what is the outcome of the condition. That will be documented by the physician. So for 99204 and 99214, for a moderate risk, they have given the example of prescription drug management, decision regarding the minor surgery, with identified patient or procedure risk factors, decision regarding the elective major surgery without identified patient or procedure risk factors, diagnosis or treatment significantly limited by social determinants of health. So we discussed about the social determinants of health. That also plays a vital role in determining the risk. So for the high risk, we have drug therapy requiring intensive monitoring of toxicity, decision regarding the elective major surgery with identified patient or procedure risk factors, decision regarding emergency major surgery, decision regarding the hospitalization, decision not to resuscitate or de-escalate care because of poor prognosis. So this is the risk table of new risk table. So this is the overall new MDM table. So finally, when we are going to determine the level that we are going to select based on the 2 out of these 3 elements. Say for example, in case we have a minimal risk, we have a minimal COPA, and we have a limited data, and we have a low risk. Since it is a 2/3, we'll consider for 99203 to 99213 based on the patient type, whether the patient is a new or established patient. So moderate, we have elements for moderate for table A, table B, and table C. And high, we do have the points for COPA and data extensive and for high risk. So, in case if we have a low, so if we have a COPA is low and data is moderate and risk is high, consider as a new patient, what would be the office level? Any answer? I repeat, COPA is low and data is moderate and risk is high. Two out of three. So this MDM table is same like the previous MDM table. It's 2/3.
Will we go to low? 203 you will go?
Any other answer? I repeat my question again. COPA is low and data is moderate and risk is high.
204 we can go. 204.
Yeah, 204. So it's 204. So since it's 2/3, it's going to be 204. Okay. So this is a description of the new MDM table. Here you can see for 99201 has been deleted. So we have only four MDM levels that are straightforward, low, moderate, and high. That is 99202, 203, 204, and 205. We do have a prolonged services code that we'll discuss in the further slides. So we do have the time criteria for each of the levels. Just like the new patient, we do have code for established patient. For 99211, we don't have any. We don't have any MDM. Okay, it's just basically it's a cases where the immediate physician presence is not required for established patient. I'm not sure whether it's applicable for in Abu Dhabi. Just you have to confirm with the first name guidelines. So 99212 established patient, that is for straightforward. 99213 is for low. 99214 is for moderate, and 99215 is for high level of medical decision making. So regarding the time, we will discuss. Regarding the total time, we'll discuss in the upcoming slides. So till now, whatever we discuss is related to the MDM. Now, whatever we are going to discuss is related to the time factor. So unlike our previous guidelines, where we used to consider if more than 50% of time should be spent on the counseling and coordination of the care. But here, as per the new MDM table, we are going to consider both face-to-face as well as non-face-to-face time. Together, we will consider as a total time spent by the physician or other qualified healthcare professionals. So except for 99211, time alone may not be used for selecting the appropriate core level of service, office and outpatient services. So not a descriptive component for emergency department level, it's not applicable. May be used to select the core level in office and outpatient services. May only be used for selecting the level of other E&M services with counseling and coordination of dominates the service. Activities included in the time: preparation, review, perform, counsel, order, consult, document, interpret and communicate, and coordination of the care. These all things included in the time. All these activities are included in the time. Activities that are not included in the time, say for example, the physician is traveling from one facility to the other facility, that will not be considered. Teaching as a part of service, no, that the teaching time will not be considered for in the time. And also, if the clinical staff is performing certain the activities, that will not be considered for total time. So here you can see the difference. Earlier also we had time, but the time which is documented in the new 2021 code set version is totally different from what we had earlier. For straightforward, earlier it was 20 minutes. Now it is 15 to 20 minutes. It is a range of 15 to 29 minutes range. For 99203 low complexity, that is 30 minutes. Now it is 30 to 44 minutes. For 99204, it is 45 minutes. Now it is 45 to 59 minutes. And 99205, it's 60 minutes. Now it is 60 to 74 minutes. Like just like a new patient, we do have a time change for the established patient also. So 99211, earlier it was 5 minutes. Now it is not applicable. So 99212, earlier it was 10 minutes. Now it is 10 to 19 minutes. 99213, it is 15 minutes. Now it is 20 to 29 minutes. So 99214, earlier it was 25 minutes. Now it is 30 to 39 minutes. 99215, earlier it was 40 minutes. Now it is 40 to 54 minutes. So please remember, even the time range for new and established patient are different. You can see here for 99202, it is 15 to 29 minutes. For 99212, though the MDM is same, straightforward and straightforward same, but the time range is different. So new patient has a different time range and the established patient has a different time range. So, but MDM is same. Yeah, for straightforward, low, moderate, and high complexity. Based on the patient type, we will consider whether it will fall under the new patient or an established patient. So time-based coding for qualified healthcare professionals. An individual who performs in professional services, which is his or her scope of practice, and independently reports the professional services, are a qualified healthcare professional. A qualified healthcare professional are basically someone who is licensed to perform the services who are billable persons. So example like nurse practitioner, physician assistant, and certified nurse specialist. The time which is spent by the physician as well as the qualified healthcare professional, both together considered for total time. So there are other clinical staff, example medical assistants, licensed practice nurse and registered nurse, that would not be, those time spent by the clinical staff will not be considered for total time. So frequently asked questions related to the time. Does the midpoint rule applies for the reporting time? No, the new codes no longer contains a typical time. Instead, each code will have a explicit time ranges. Is it true that when counting time you can count time the day before? No, that is not true. The time spent only on the time spent may only be counted if it occurs on the same day as the face-to-face office-based services. If you use an interpreter to take history and do teaching, is that considered part of the regular time? There is really no way for us to separate out the time spent by the interpreter or relay the information. The additional time it takes to use an interpreter may be included in the total time calculation for these E&M services. So if the patient is having a language barrier. So if there is an interpreter is placed, okay. So if the patient wants to perform the treatment, he has to get the information from the interpreter, the language translator. So the interpreter time will also be considered for total time. So we can understand that cumulative time is cumulative throughout the day. However, does that also go for multiple providers? Say, for example, a patient seen by Dr. A in the office, the time spent was 25 minutes. Later the day, the mom calls back to discuss a medication question, and another physician in the office explains, and it has prescribing physician was not available. The call lasted for 7 minutes. Both physicians are pediatricians. Can I add up the time? Yes, so long as the time spent on the same day, it is cumulative with the same physician and same physician of the same group practice. Yes, we can sum up the time. So next we are going to see about the prolonged services. We do have a new code for prolonged services, that is 99417. This prolonged services code is an add-on code which we are going to use along with the highest new EM level, that is 99205 for established patient, that is along with 99215. So the time duration for this 99417 is 15 minutes. We have a time limit. So code 99417 is used to report prolonged total time. Is combined with time with or without direct patient contact provided by the physician or other qualified healthcare professional on the date of office or outpatient services which is performed. When reporting 99417, the initial time limit of 15 minutes should be added once the time of the primary EN code has been surpassed the 15 minutes. So here I had given the table. So you can see here for the level 5.
You're on mute, Umar.
Someone is muted. So, was I am audible regarding the time discussion? May know from which slide? Yeah. Okay. So once again, regarding the prolonged services, we do have a new code for prolonged services. So we do have a new code for prolonged services, that is an add-on code 99417. This add-on code has a 15 minutes of time limit, which we are going to use along with the new E&M service code, that is 99205, or with the established service code, that is 99215. So we can see here we are not going to use the prolonged services code with the level 3, level 2, 3, 4. Okay, we are going to use this prolonged services code only with the level 5, that is high, with the final code of new patient and the established patient. So we do have a time range for 99215, that is 40 to 54 minutes for established patient, and for new patient the time range is for 99205 is 60 to 74 minutes. In case if you are going to add the prolonged services, it should have surpassed the 15 minutes from the base time. Say for example, you can see here for 99205 the base time is 60 minutes. If the patient has provided the total care for 60 minutes, we will report 99205. If in case from 60 to 74 minutes, the code remains the same. If in case the time duration has exceeded 75 minutes, then we can add an additional code along with the 99205. We can add 99417 once. Same for the established patient. The time base time for 99215 is 40 to 54 minutes. If in case the patient has spent 55 minutes with the established patient, yes, we can report 99215. Along with that, we can report 99417 once. Likewise, for the every 15 minutes of interval, we can add the units for prolonged services 99417 into 1 or 2 or 3 based on the 15 minutes increments.
How about in emergency, can we use the prolonged service?
I didn't know. Can you repeat that?
In emergency service, sometimes there will be a prolonged service. It can be used. Emergency visit. Yeah. I think you are on mute.
Umar, unmute it.
Unmuted, but however, someone is muting again. So the answer for the question for emergency department, emergency okay, the answer for the previous question is for emergency department is not a time-based code. 99281, 282, 283, 284, 285 is only based on the MDM levels. So here this 99417 is it's a time-based code which is applicable for office and outpatient services.
Thank you.
Okay, so next is split share visit. I knew that there is some difference of guidelines which is followed on the actual guidelines and which is a modified version just used in UAE. So split share visit again you have to follow what is being used in the local guidelines. So split share visit, physician and other qualified healthcare professionals jointly provides a face-to-face and non-face-to-face work related to the visit. Any specifically identified procedure can be reported separately for either for the physician if the physician has performed the services or the qualified healthcare professional who has performed the services. The ordering and actual performance or interpretation of diagnostic tests not included in the determining the level of the E&M services. The tests that do not occur as separate interpretation and are analyzed as a part of EMDM do not count as independent interpretation. So in case if you are going to separately build the procedure, we are not going to consider for the E&M level. The physician performs a diagnostic test studies for which a specific safety code are available, report separately. Physician interpretation of the results of diagnostic test studies may also be reported separately with consensus modifier. So when counting the time for split share visit, when the physician and other qualified healthcare physician performs a E&M, the time spent by each is summed for the total time. Say for example, the PA spends 30 minutes and the physician spends 15 minutes. So the total time would be 45 minutes. So counting the time for split share visit. So in case the physician has performed 15 minutes of time with the patient, established patient, and the PA, the qualified healthcare professional, has spent 30 minutes. As a cumulative time, total time would be 45 minutes. 30 plus 15 minutes. The code will be 99215. So frequently asked questions. So how to determine if if a procedure is major or minor when assessing the risk in new E&M guidelines for office visit? Here that the AMA is saying that it is surgeon's judgment and not the global days that determines if the procedure is major or minor. Is that right? The answer is yes. Solely for the purpose of determining the level of risk using the new office visit guideline, the AMA said at the symposium not to use the global days to determine if the procedure is minor procedure or major procedure. So the next question is, if the physician orders a MRI at a visit on September 20 and reviews it with the patient on the follow-up visit, can we give credits for ordering on September 20? And can we give credits for review on September 27? That was the question here. As I said earlier, no, we cannot give credits in the subsequent visit for reviewing. When the physician has ordered the test on September 20, the review is a part of the test. It means the credits will be given, the order itself consists of the credits for review. So we cannot give separate credits for reviewing the test on the subsequent visit. So if in case a different physician is ordered and a different physician is going to review, then we can give the credits for reviewing. So if I'm leveling the visit-based total time and have also provided the information in time-based services, say for example, advanced care planning, tobacco cessation, how do I document the time for those services? So there are certain safety codes which are the time-based services performed, like a tobacco cessation counseling session. So the total time which was performed, we have to carve out the time which is performed for E&M services and the time which is performed for counseling. Here the patient is, the total time was 25 minutes. Out of the 25 minutes, 5 minutes was spent for the tobacco session counseling. So 20 minutes, the balance 20 minutes will be considered for leveling. So the final code will be 99213 with modified 25 along with the tobacco session counseling code, that safety code, that is 99406. So let us move on to the clinical scenarios. So you guys want to try? I'll give some time. As well as new guidelines. Anyone like to try?
So level 4
So-
it will go.
99213 now.
Yes.
95 guidelines it will go. So
Yeah, 95 guidelines, it will be 99214. But as per the new guidelines, it will be 99213 because the patient came with acute uncomplicated illness, and that is patient has having acute fever, abdominal pain, and there was a test, only one test was ordered, entered, and the rest table would be a prescription drug management, that will be moderate. So 99213. So clinical scenario 2. I know that it's a lengthy case study. So I will give you some time just so that you can go through the slide. So I have the rationale in the further slides. So once you review, just inform me so that I can move on to the next slide. So here the patient tested efficient claim to follow for stable fatty liver. The documentation is as follows. Female presents with non-alcoholic fatty liver. She has no other complaints today, no other chronic condition. She denies fever, weight gain, swelling, skin color changes. She also denies any confusion. She continues to work at her regular job and reports no difficulties there. She denies unusual bleeding or bruising. Energy is good and diagnosis was made 3 years ago instantly and on ultrasound. Condition has been stable since the initial full evaluation. For objective blood pressure 124/70, pulse, disease, temperature, and BMI, general well appearing. So everything is normal. So general examination is normal. So the lab reviewed and analyzed CBC, CMP, and the labs are reviewed. The ultrasound, last ultrasound was taken 3 years ago, and assessment non-health alcoholic hepatitis. Plan liver function test continue to improve. Since initial diagnosis, 30-pound intestinal weight reduction, continue monitoring appropriate labs at 6 months interval. Follow-up in 6 months or sooner if swelling, bruising, or confusion. Avoid alcohol, continue weight management. She is reassured her condition is stable and had no other questions or concern, especially in light of her previous extensive education on the topic. I'm arranging for hepatitis A and B station, discuss OTC medication, vitamin E, and for now we'll avoid them. So the ANA level will be 99213. The rationale is the patient came with one stable chronic illness, which is an example encountered for problem low in the number of complexity, and the risk of complication from the treatment is low. The objective session indicates the review of 3 lab tests, which qualifies for the moderate and a moderate amount and complexity of the data reviewed and analyzed. However, the level of MDM requires meeting 2 out of 3 bullets. So the overall level will be low. That is 99213. Shall I move on to the next scenario? I knew that it's quite tricky when comparing to the previous MDM table. So once we use to the key terms, then we'll feel comfortable. So even if you're not able to understand now, once you start with the once you start applying the new concepts to the records, it will be quite easier. Honestly speaking, the comparing to the old MDM table, the new MDM table is quite easier. The only things we have to focus on the key terms. How we have to fix which condition falls under which definition. Okay, so let us move on to the clinical scenario 3. An established patient with obesity and diabetes presents with the new onset right lower quadrant pain, and the documentation is as follows. Subjective, the 42 years female presents with evaluation of 2 days of abdomen pain. She has a history of type 2 diabetes mellitus controlled. Pain is moderate, sustained, and 10 at worst. The pain is intermittent. The pain is located in the back and right lower quadrant mostly. She denies diarrhea or vomiting, but does note some nausea. She denies fever. She denies pain. She is sexually active with her spouse, and she has had a hysterectomy due to severe dysfunctional bleeding. She has not tried any medication for the relief. No position seems to affect her pain. She has not had symptoms like this before. Home glucose check have been in 140 for fasting. Her last A1C was 6.9%, 2 months ago. Family history. Okay, these are just an history part, so it's not going to. So objective patient general, he has a mild to moderate pain. I think rest of abdomen has right side tenderness, and the rest of the things are normal. Urine analysis with microscopy, CBC, CMP. So the patient is assessment as abdomen pain and diabetes type 2 controlled obesity as the risk factor of gallbladder problems, but still favors renal stone. Keratolux 60 mg injection was given for pain relief. Hydrocodone prescription was given for pain relief. Discuss and length of suspicious renal stone. Will plan lab work and pain control and await CT stone studies. Urine sent for reference lab for microscopy. Advised to drink plenty of fluids. Urine strainer is provided. Call the office if worsen or persistent symptom. Awaiting lab CT for the next step of treatment plan. Will follow up with her if urology referral is indicated. So the level will be 99214 because the patient has one undiagnosed new problem with uncertain prognosis. See here, the patient is having abdomen pain. It's an undiagnosed new problem, and the patient suspects patient might have renal stone. So, what was the prognosis of the condition? That determines undiagnosed new problem with uncertain prognosis. Earlier, I just gave an example of the lump or mass because that would be easy for understanding the concept. We can apply any condition. If the patient is having a differential diagnosis, the patient came with certain complaint, and patient is not able to determine what will be the prognosis, what will be the outcome of the condition, that will fall under the undiagnosed new problem with uncertain prognosis. And also, the patient has a two stable chronic illness, that is diabetes and obesity. Either one, the new problem with the uncertain prognosis, or two stable condition meets the definition for moderate. Okay, so let me show the MDM table here so that once again you can recollect. So you can see here in moderate, you can see one undiagnosed new problem, the uncertain prognosis, and two or more stable illness. So either one we can consider for moderate. Here the patient is having abdomen pain and not sure whether the patient has a renal stone. So that will fall into the undiagnosed new problem, uncertain prognosis. And also the patient has obesity and diabetes. That will fall under two or more stable chronic illness. So let's move. The rationale continues. The physician reviews and orders total of 4 tests for which exceeds the requirement of the moderate data, but does not meet the requirement for high category. So here the physician orders 4 tests. So if as per the category 1 in moderate, the physician performed done with 2 or 3 orders, that itself satisfies for category 1. So for moderate, either the one of the 3 categories should have met, either category 1, category 2, or category 3. So the data would be the moderate. The prescription drug management is given. So the moderate risk. So the overall MDM will be 99214. So clinical scenario 4. The established patient with a new lung mass and probable lung cancer presents with the desire to initiate hospice services and forgo curative treatment attempts. The documentation as follows. A 92 years old male presents with follow-up of hematoxis, fatigue and weight loss, along with the review of the recent chest CT. He reports a moderate mid back pain and new since last week. After his fair, he denies fever. He continues to have an occasional cough with a mixed blood in a product produced sputum. Subjective weight down 5 pounds. BP is 135 to 180. So 135 to 80. And BMI is 18.5. Oxygen saturation is 94%. Patient is generally frail, appearing elderly male. No distress or shortness of breath. Able to speak in full sentence. ENT is normal. Lungs frequent coughing and diffuse breath sounds. Heart regular rate and rhythm. Estimated no estimated swelling. Moderate tenderness. CT shows a large right side lung mass suspicious for malignancy, along with moderate left side effusion lesion seen in the T68. So assessment lung mass suspected malignancy with bone metastasis. After the extensive review and finding, the patient was informed of likely poor prognosis of the suspected lung cancer We reviewed his living will. He reiterated that he did not desire life prolonging measures and would prefer to allow the disease to run its natural course. He also declines additional testing for diagnosis or prognosis. A shared decision was made to initiate hospice services. Specifically, we use need for oxygen and pain control. He declines pain medication as of now. Will let us know, but will let us know. He and his son, who was accompanying him, voiced agreement and understanding the pain. So, patient here, the level will be 99215. The rationale is as below. The patient has one acute or chronic illness or injury, suspected lung cancer that poses a threat to life or bodily function. So as per the new guidelines, the COPA will be problem address will be high, and patient review want a CT so the amount of complexity is minimal. A decision not to resuscitate or de-escalate care of poor prognosis is an example of high risk. The decision was made not to resuscitate or de-escalate care. So the risk will be high. Overall MDM 2/3. So the final level will be MDM will be high. Since the patient is an established patient, the final level will be 99215. So this is regarding the case scenario 4. So another clinical scenario we have. So this is the last clinical scenario for the session. An established patient presents with a 3-month history of fatigue, weight loss, and intermittent fever, and new diffuse adenopathy in splenomegaly. The documentation as follows: 30-year-old healthy male with significant personal history presents with a 3-month history of fatigue, weight loss, and intermittent fever. He travels for work and has been evaluated by several urgent care centers. Reassured that he likely has a viral syndrome. Fever have been as high as 101, but usually around 100.5, typically in the afternoons. Testing for flu and acute mono has been negative. He denies high risk for sexual behavior and IV drug use. And he denies any sick contacts. He has not had vomiting or diarrhea. He has not had any pain, and he denies cough. Objective blood pressure is 125/80, per centimeter is 92, BM is not 27.5. General is well-nourished male, everything is clear. Second, multiple protection is noted, and then multiple cervical, ancillary, and including lymph nodes are enlarged, mobile, and non-tender. Assessment is weight loss, lymphadenopathy, and splenomegaly. Prior to the visit, I spent 15 minutes reviewing the medical record related to his recent symptoms and various urgent care visits. We reviewed the differential at the length to include infectious disease and acute myelodysplastic condition. I ordered the blood cultures, TB test, EV titers, ECO, and CBC. The pathologist called to report concerning findings on the CBC for likely acute leukemia. I called the patient to inform him of his result and need for additional testing. I also discussed the patient with oncology and arranged for a follow-up visit for tomorrow. I spent total time of 92 minutes with the record review, exam, and communication with the patient, communication with the other providers, and documentation of this encounter. So totally, patient has spent 92 minutes. Next, patient is an established patient. So anyone like to try the level? Anyone like to answer the level? So this is the last scenario for today's session. So total 92 minutes, established patient. Any answer? My voice is audible?
99215 test 99417.
Yes.
Times 3.
Someone was answering. Yeah,
Yes,
your
yes,
answer is correct. 99215 and 99417.
417 times 2. Yeah.
Times. So 99215, the base time is 40 minutes. So from 40 minutes, we are going to calculate. So the additional time will be the additional 3 units we can add. So because it's 92 minutes, first 15 minutes is 99417. And again, we are going to add another 2 units. So cumulatively, it will be for 92 minutes, 99215 and 99417 Lambda services into 3 units. So any questions, team? So
Morning, Kumar.
I hope,
Yeah, this session is very good session. Thank you for your good knowledge.
yeah, I hope
And-
this.
The questions are rising. Questions are there, but still, I will mail you regarding this. Okay, thank you.
So I repeat, I knew that the guideline which is followed in the local guideline which is followed in the UAE is quite different. We have slight modification. Whatever session I took today is basically on the AMS CPT 2021 guideline. So if in case there is any further changes or further updation, modified version is followed in the local based on the local guideline, that would be appropriate to follow as per the location. Yeah, that's all for today's session. Over to Sheikh. Awesome.
In next year,
Someone
we have
raised
to
the
follow
hand.
1995 guideline or 2021 guideline. We have to follow 1995 guideline or 2021 guideline. The end of next year. Okay. Okay.
Hi, good afternoon. Thanks for the informative session. This is Silas. I mean, like, you'll be sharing the presentation, right, across. Okay.
So I have two questions. So you are telling, so if a unique test, so if the same lab with a different variant, can we consider as a different points for MDM? For example, if influenza A and influenza B has been tested, so can we consider a 2 point in the table B?
That will be considered as 1 unit test. So that was an example which we discussed on the slide. If we have two, say for the same overlapping test, if you do have 2 different safety codes, that will be considered as a 1 unit test. If in case, in this case, if we have 2 different safety codes and if this performed 2 different cases, then it will be considered based on the case.
Okay. So, another point, if X-ray, another question. So X-ray is ordered by the same physician, and radiology is performed X-ray, and the physician is providing interpretation separately. Can we consider as a result review or independent interpretation in this case?
Can you repeat the question again?
So X-ray is ordered by a physician and performed by a radiologist.
Okay.
And the interpretation, X-ray interpretation given separately by a physician. In this case, can we consider it as a result review or independent interpretation?
The first patient whom you said and the last patient both belong to the same group practice, right?
Sorry, your voice is breaking. I'm not getting you properly.
Okay, let me reframe this. So let me reframe the center. I'll reframe your questions if I'm not wrong. So there were 2 group of physicians from the same group. One senior physician has ordered the test, and the test was performed by the radiologist, and there is other physician from the same group who is giving the interpretation. So the answer is yes, we can give the credits for the interpretation.
If the same physician is ordered, same physician given interpretation means we can consider as a result review.
That we can consider for interpretation. We cannot consider for review. We can consider.
We cannot consider for interpretation. I'm asking the lab test result review, right?
Yes.
Test result review, category 1, test result review. Can we consider as a X-ray interpretation?
If we are going to if you are going to give the credits for interpretation, we cannot give credits for review.
Okay. No, if generally if I am getting an X-ray chart, so the physician A is ordered the X-ray, and radiology perform the X-ray, and physician A is providing an interpretation. There is only one physician is performed. That physician is ordered and providing interpretation. So in this case, can we should I consider as a test result review or independent interpretation? That is
we can consider for independent interpretation.
Independent interpretation.
Yeah, when in a real live practical scenario, we can see there are a lot of tests has been ordered. There will be multiple tests will be ordered. When it comes for interpretation, only the most probably the radiological studies will be interpreted. So it will be better we can consider for the interpretation point, so that we will have a point for category, either in the moderate or extensive for data.
So we cannot consider as a test result.
Yeah. For
so
orders,
we can consider as independent.
Yeah, we can. For order, we can have multiple orders.
The X-ray order also we cannot consider as a unique test order.
When we say order, it is not only for the lab test. Any test which has been ordered, we can consider as an order. Whether it can be lab test or whether it can be a radiological test, any test or either pulmonary function test, any test which has been ordered, we can consider as an order. Order is not specific to the laboratory test.
Actually, Umar, the lab and test radiology.
And one more question. So the acute illness with the systemic symptoms, can we consider if a patient having a bronchitis or any? Sorry. Umar, can I ask my question?
Yes.
Am I audible?
I think there is some background.
Okay. So if any respiratory illness, in this case, we can consider the respiratory rate for the systemic illness.
The systemic illness, no. Systemic illness, something like fever, fatigue, which the whole body system is systemic illness. They cannot consider the symptom of that particular condition itself. Along with that, if patient is having bronchitis, obviously the patient will have some respiratory difficulty. Along with that, the patient is having fever. Fever will be considered as systemic symptoms.
Okay, good. Thank you for your.
Excuse me, sir.
Yes.
This is Srina. I think fever is not a symptomic because a fever is a common symptoms.
Whatever I responded, that is based on the definition which is given in the key tabs.
Okay, thank you.
So I repeat again, whatever the examples which I noted for the each key terms, okay, that is something which I have used only for the solely purpose of explaining the key terms. So it doesn't mean that only those examples or those examples are indicative for that particular terms.
If you don't mind, could you please tell about the telemedicine guidelines in Could you please tell about the telemedicine guidelines in yes, sir. Yes.
The-
Within 7 days, I think within 7 days there is, I mean, if patient come, I mean, within 7 days, if patient came for same problem, then is it billable or not? Yeah, yeah, I have. Yes, yes, I have a doubt on that. Yeah, I have a confusion on that. That's why I asked you. Yeah. Okay, sir. Could you please explain modified 27? So most of the people says that 24, 25. I think it's implemented, sir. Most of the people says that ENM modifiers like 25, 24. Then some of the people say that 27 also is used in ENM. So yeah, okay, sir. Sir, if you don't mind, could you please tell about 52 and 53 modifiers with example? I just want to clarify. I mean, I know the meaning because reducer services for 52. 53 means discontinued. I mean, in what scenarios we use it, sir? So, okay, sir. Thank you. Yes.
Very good. Yeah. I would like